My name is Kelsey Gross. My project is about evaluating the effectiveness of different laws in implementing ratios for adequate nurse staffing levels in hospitals. Nurse-patient ratios are crucial for ensuring adequate patient safety and care. Previous research has showed that adequate nurse staffing, so having enough nurses on a floor so no nurses are overloaded with too many patients, improves outcomes for patients as well as the nurses' quality of care and job satisfaction. Some states and countries have taken initiatives to encourage or mandate hospitals to maintain adequate staffing levels. Some policy techniques used to do so are public reporting, staffing committees, and mandates. As of 2017, 5 states use public reporting, in which hospitals compile the average nurse-patient ratios across different units and report these to a public domain. The goal of this type of policy is to empower consumers with information that could impact the quality of care they receive when they choose what hospital to attend, and to incentivize hospitals to maintain adequate staffing so they do not look worse than their competition. However, there has been little research on the effectiveness of this type of policy. Many consumers may not understand the impact of staffing levels, know how to access these reports, or care about staffing levels at all. Consumers may instead prioritize hospital location, for example. Consequentially, the hospitals may not necessarily see their low performance on the public reports as an incentive to change if they are performing well in other ways. More research may be helpful. Staffing committees are another method states implement to determine safe staffing levels. As of 2017, 7 states had staffing committee laws, which require hospitals to report back to the State Department of Health with a staffing plan created by a committee consisting of at least 50% staff nurses. This type of law allows hospitals and nurses more flexibility to create plans accounting for individual hospital characteristics and gives staff nurses a direct voice in the formation of staffing plans. However, there is little research on these laws' effectiveness, and there is no set method for state health departments to enforce the staffing plans created by the hospitals. Mandates are a third political tool governments can employ to ensure adequate nurse staffing. Mandates, laws dictating the nurse-patient ratios all hospitals in the jurisdiction must maintain for different types of floors, are unique because they actually require hospitals that are not following the policy to change. Currently, the only state that has a nurse-patient mandate is California, although Massachusetts put one on the ballot this fall, which did not pass. In California, depending on the unit, one nurse may not take care of more than a designated number of patients. In contrast, a mandate in Victoria, Australia, passed in 2015, requires an average nurse-patient ratio per floor, also based on the type of unit. The Wales mandate, passed in 2006, takes a more hands-off approach, simply requiring all hospitals to follow ratios set by regional health boards. My research mainly centered on the effectiveness and impacts of mandates, since they are more controversial and there is also more prior research on these laws. Obviously, mandates force hospitals to meet safe nursing ratios set by the law or face fines. As described above, this can improve quality and outcomes. Although some hospitals may be initially opposed to the additional cost of hiring more nurses, research on California's law showed that over time, compliance with the mandates saved hospitals money by avoiding the cost of adverse outcomes, such as hospital-acquired infections or readmissions, that can result from inadequate staffing. Likewise, set staffing ratios are definitive and clear, making these laws easy to understand and follow. Some nurses and hospital administrators in opposition to this type of law argue that setting mandates makes nurses and nurse managers lose autonomy over their floor's caseloads and break times compared to less aggressive policies, such as staffing committees, and that these laws may put nurses at a disadvantage based on specific hospital characteristics and takes too much of a one-size-fits-all approach. I have been working with Dr. Matthew McHugh in the Penn Nursing Center for Healthcare Outcomes and Policy Research to explore the impact of a mandate law passed in 2016 in Queensland, Australia. This mandate is designed like the Victoria mandate, with an average ratio per floor, and in its beginning, only a select group of hospitals were designated to be subject to the mandate. In spring 2017, a baseline survey conducted on hospitals in Queensland established that 67% of the selected hospitals would need to change their staffing levels in order to be compliant with the law, and that the hospitals designated to comply had higher incidences of costly adverse events. Two bills, both called Nurse Staffing Standards for Hospital Patient Safety and Quality Care Act of 2017, were introduced to the House and Senate in 2017. These laws were national ratio mandate laws, which mandated ratios based on unit type and allowed for staffing committee formation as well. The bills were sent back to committees after introduction, and the results of our Queensland study and further follow-up on the hospitals that followed the mandate may directly impact the outcome of this bill in the United States if and when it is reintroduced. Overall, I believe the benefits of nurse staffing ratios outweigh the costs, but I am excited to be at the forefront of further research that is to come. I think it would be helpful to know more about the impacts of public policy laws, to have further long-term research about the cost-effectiveness of increasing nurse staffing, and to have more research done on the effectiveness of using specifically RN licensed nurses rather than nursing assistants. I think mandates are the best policy, but based on existing research, I believe it is important to help nurse managers maintain autonomy and allow for some flexibility within the mandates. Right now, mandate or not, I believe the evidence is that struggling hospitals could benefit by hiring more nurses. Although this may seem counterintuitive from a business perspective, this could improve costs in the long run with fewer adverse outcomes. Thank you. Here are my references.